Deep anterior lamellar keratoplasty with large perforated Descemet membrane. This patient had scar in the middle and decided to do deep anterior lamellar keratoplasty as the anterior segment OCT showed an intact endothelium and Descemet membrane. As you see here, there is some vascularization. After doing 6 quadrants of the Baron terrifying to cut 400 thickness of the cornea, deepening the edges, and vascularization showed some bleeding, so cauterization at the periphery to decrease the bleeding. Having deep enough stroma and through the insulin needle injected in the deep stroma to create a big bubble to separate between the stroma and the Descemet membrane. As you see here, the big bubble had been formed, but some of it had been entered in the anterior chamber and it wasn't completed at the upper temporal quadrant. Then passing the spatula after doing the brave slash to separate between the stroma and the Descemet membrane. When the spatula passes through the stroma, between the stroma and the Descemet membrane, the path should be very smooth as if it is in the anterior chamber itself, not through the stroma of the cornea. Having any resistance to pass through the cornea, this means that we are not in the correct plane. But having no resistance at all between the stroma and the corneal endothelium, it means that the spatula is in the right plane. Dividing the 4 leaflets of the corneal stroma and exposing the endothelium, taking care not to touch the endothelium in order not to open this Descemet membrane and the endothelium. And of course, this is type 1 bubble. As you see, the bubble was large, 8.5 millimeter with high pressure, and it extends to the limbus with white edge at the periphery. Then dividing the 4 quadrants and exposing the Descemet and the endothelium with the rough surface because it is type 1. Removal of every quadrant, and here, because the bubble was not so completed, you'll find some of the edges of the deep cornea are still present, which we call it the ledge of the cornea, that may sometimes hinder the healing of the donor and the recipient. But taking care here, there is no separation, and the cut of the stroma will open the Descemet because the bubble did not reach this area. In slow motion, here is the Descemet membrane is open, large perforation, not a small perforation, and this perforation is left for a while. Get injection of air bubble inside the anterior chamber to reform the pressure of the eye, removal of the rest of the stroma from the endothelium in the other quadrants, leaving the area where the perforation happened, facilitating the removal of the stroma from the endothelium, taking care not to cut the Descemet membrane and the endothelium at this area. And the last part to be removed is the area where the perforation had happened. After removal of the total stromal area and seeing what's left from the endothelium and the Descemet membrane, you can unfold it and stretch it as if it is intact again because the perforation is peripheral in spite of being large. This was young age donor, so the endothelium was removed with the trypan blue and the sponge, and taking the 8 millimeter donor to put on the 8 millimeter recipient with no difference in the ectatic diseases in order not to induce myopia. After taking the cardinal sutures, the 12 o'clock one, and then the most important, the 6 o'clock, to divide the cornea into exactly 2 halves, then taking the other 2 at 3 and 9 o'clock to create a cruciate-like gutter of the cornea, then taking the 16 sutures. Then don't inject the air from the area where you opened first because it is near to the Descemet perforation, but to do another step one to inject the air from the area far away from the Descemet to stretch it and fill the air inside the eye. after being sure that the air filled the whole eye. This is the case after 2 months, showing clear cornea in the center, having the anterior segment OCT showing some separation of the Descemet membrane immediately after surgery. 5 days later, the Descemet was more intact, and after 1 month, there is a total adhesion of the Descemet in its place, meaning that even in Descemet with large perforations, you can continue to do your DALK. Thank you very much.